Hi, welcome to another episode of Ask the Expert, a series of presentations provided by the Bay Area Association of Kidney Patients, or BAAKP, which is an all-volunteer organization staffed by kidney patients themselves here in the San Francisco Bay Area, and we are dedicated to providing patient support and information about kidney disease and kidney transplant to the patient community here. My name is Ben Lee. I'm on the board of directors of the BAAKP, and I have the honor of sitting here with Dr. Stephen Katznelson, who is the medical director of the kidney transplant program here at the California Pacific Medical Center, or CPMC, which in turn is part of the Sutter network of hospitals here in Northern California. Dr. Stephen Katznelson is also on the board of directors of the Sutter West Bay region, as well as on the board of the Pacific Foundation Medical Associates. Dr. Katznelson, thank you very much for joining us. Before we get started, I'd like to let you know that this conversation will be broken out into 3 video segments so that you can go to the next segment that you feel is relevant to you. We will cover 3 major topics. First, we will talk about the kidney transplant program here at the California Medical Center as an alternative to some of the other programs that you may have heard of here in the Bay Area. Second, we will address a relatively new development in kidney transplant called pair donations, which you may be very interested in learning about, as it can make a difference in terms of the waiting periods for transplants. And lastly, we will talk about some new developments in the rules and how kidneys for donations are allocated. So please, if you find some of these other topics interesting, you can look for these other segments on the site. So with that, let me move on to the first part of our segment, which is a little bit about the transplant program here at CPMC. Dr. Katznelson, again, thank you for your time. So tell us a little bit about the transplant program here at CPMC. Can you give us a little bit about its background?
Certainly. Well, first of all, thank you so much for inviting me to participate in this program. CPMC has been doing kidney transplants for quite a while. I believe the first one was in 1969. And it really heated up in the 80s, where a pancreas transplant program, a liver transplant, and heart transplant program were all added. To date, we've done over 5,000 kidney transplants, and over the past years have performed about 200 such procedures a year. So it's considered a fairly large transplant program. There are about 2,300 or so people on the kidney transplant waiting list. That's good and bad. It's good because it allows us to take care of a lot of people through their transplant, but it's bad because that means there are too many people waiting for their kidney transplants, and this is a huge problem through the country. CPMC has specialized in several niches in the transplant world. And one of them, as we'll talk about later, is kidney pair donation, which has been relatively new to us over the last 6 or 7 years. We're also a very large pancreas transplant program, and I believe we perform the most pancreas transplants in Northern California. Most of those are simultaneous kidney and pancreas transplants for some of our diabetic patients.
That was in fact going to be one of my questions, which is do you do kidney and pancreas simultaneously? So that's definitely.
Yeah, so we are a big pancreas transplant program, but the unique part of it is not just the size and number of transplants, but we're one of the few transplant programs who actually do pancreas transplants for some type 2 diabetics. Originally, and in most programs, pancreas transplantation is for type 1 diabetics.
Okay. And to be clear, for some of the patients who may not understand quite the distinction, type 2 tend to be the adult onset. Is that the case?
Yeah, one of the terms for it is adult onset. The main distinction for us, though, is that any pancreas transplant candidate has to be on insulin, and some of the adult onset, many of the adult onset diabetics are not on insulin. So this is really for insulin-dependent diabetics, either type 1, by definition insulin-dependent, or type 2.
Interesting. Okay. So that when the progression of their condition along with the kidney transplant, that's when you perform the entire procedure.
Yeah.
Okay.
And though we'll be segueing to it in the last segment of our talk, one interesting variation in the current allocation system for people who are reasonable candidates for pancreas transplant is that waiting list is actually fairly short.
Oh, interesting.
So if you were to compare, say, a blood type A individual who was 40 years old and waiting for a kidney transplant in this part of the world, they may wait 5 years for a kidney transplant. If they were a good candidate as an insulin-dependent diabetic for a kidney and pancreas transplant, that wait may only be a year to a year and a half.
That's interesting. Why would that be the case? That if you're waiting for 2 organs, that it may be a little bit faster?
It's a bit odd the way the allocation system has come about. But what happens is if you need a kidney and a pancreas, it's the pancreas that you're really waiting for. And in this area, there's a relative abundance of pancreases as compared to the need. And so supply and demand would say that the wait is relatively short. And so once someone is allocated a good pancreas, in a sense, the kidney comes along with it.
Interesting. Okay, so you're looking at more as a pancreas transplant. That's very interesting. Now you mentioned a little bit about the differing wait times. Is my understanding is that the wait times for the San Francisco Bay Area tends to be a bit long, right? Is the wait times here at the CPMC program comparable to the other programs that are in the region?
Yeah, so there are 3 adult kidney transplant programs in our area. Our area is defined by an organ procurement organization, or OPO. It's a non-profit that takes care of the allocation of kidneys to all those programs and the people on those waiting lists. Because all 3 programs, CPMC, UCSF, and Stanford, draw kidneys from the same OPO, from the same area,
I see.
all the patients on those waiting lists have a similar waiting time.
Okay.
So for example, the same patient who's on the Stanford waiting list and our waiting list would have about the same waiting time.
Okay. Another question that I have just kind of jumped out at me is thinking, based on an earlier conversation we had, is do you also perform pediatrics transplants as well here, or is that a highly specialized type of transplant?
Pediatric transplant programs are distinct from adult transplant programs. Okay. And we do not do pediatric transplants. We're an adult only. So almost all of our recipients have been 18 and above.
Okay. Another question that I have, again, thinking from the point of view of a patient who may be with a particular provider or a network of care, what are the typical systems that you take referral from? And I'm asking this question because I'm thinking, for example, Kaiser tends to refer to UCSF for their transplants. Do you have other similar types of major care organizations that tend to refer to CPMC here?
So Kaiser is a unique instrument in that way. They have a locked contract with UCSF and UC Davis in Northern California, and it's a fair number of patients. It actually adds up to about nearly half of the kidney transplants done at UCSF. CPMC has contractual agreements with most of the other big payers.
Okay.
So we drop most of the insurances in the Bay Area.
Okay, so it doesn't matter if most insurance will cover coming to CPMC.
Yeah, and in fact, about 2/3 or 65% of all of our transplant patients are Medicare.
Oh,
Prime.
Okay, all right.
And so those are virtually allowed at any transplant center. And then another 10 to 12% usually are Medi-Cal. There are some local Medi-Cal programs that do not have contracts with Sutter, but most do locally.
So if you were a patient and you're learning about CPMC and you're very interested in seeking out this program, what should the patient do?
So we have some contact information, which we can talk about later if you like, and a website.
And we can certainly put it on the website, yes.
There are direct call lines they can call in to initiate an evaluation. Because we are nestled in an area with significant amount of competition locally, we've taken to the highways with our transplant team and do a lot of outreach. We have outreach sites throughout Northern California and Nevada. And in the end, about 72% of our transplants come from outside of what's considered the Bay Area. And the reason I'm discussing this is because we actually have outreach nurses who are embedded in those areas and are the main source of referrals into our program. So most of the dialysis units and referring docs will refer actually to our nurse coordinator, who then brings the patients in for evaluation clinics. We have clinics, big clinics in Fresno, Modesto, Sacramento, Redding, Reno, and other, San Jose.
San Jose, okay.
Yes. The goal with that really is to, in a sense, bring the transplant care to the communities, and not only, and importantly, the education piece, where we can one-on-one or with dialysis units talk to patients about transplant, but do their evaluations there. The transplant event is here, but then we do post-transplant care in most of the bigger clinics that we have. So really they can spend most of their time in and around home rather than traveling back and forth from service to
I see, okay. Now you mentioned a little bit about, you alluded to your transplant team earlier in the mention. Can you tell us a little bit about the transplant team here?
So the transplant team is large. It's particularly large for our size of transplant programs because of the size of the outreach service. We have 5 transplant nephrologists. That's like me. I'm trained as a nephrologist and then have further training as a transplant specialist. So there are 5 people like me here. And then we have 4 transplant surgeons who are mostly on site doing the surgical procedures and seeing patients on site, while we both see patients on site, the nephrologist, and travel to the on site. We are just part of a big team. We have dozens of nurses who work with us both on the pre-transplant side, getting patients into us through referral, through the transplant evaluation process, and then a separate set of nurses who help us case manage after the transplant. We have social workers and financial coordinators and physician's assistants, all who work towards the goal of patient care.
The full spectrum of care, just because it's such a complex thing as a transplant. Now, correct me if I'm wrong, but your role and the surgeon's role are different, right? So you in particular, but also the other nephrologists for transplant, you care for the patients post-surgery, right? You have a different group of surgeons who perform the transplant surgery?
Right, so our job really is to get people into the program and see them through the evaluation process. In a sense, help take care of them on the waiting list while they're getting to the place where they can be transplanted. The surgeons then do the surgery and help take care as an inpatient, and then me and my group, again, as you mentioned, take care as an outpatient after surgery.
Now, again, from the point of view of the patient, they may be interested in the intake process, or what are there any unique things you'd like to share about, or things that may be notable about, getting into this program? Because obviously, typically with kidney transplant programs, you have to almost apply for the program and to go through a kind of a process. What are some of the things that they should know about what would qualify them as a candidate for this program?
So my answer has 2 parts to it. First off, we very much look at ourselves as a consulting service, and it's the role of dialysis units and dialysis providers and actually providers of people with the end stages of renal failure to look at their patients and evaluate them on a yearly basis for types of end stage renal care that they would like to consider, dialysis, transplant. And we consider ourselves a consultative service so that the referring doctors and dialysis units can look to us to help make decisions as to whether or not someone is a good transplant candidate. So we have very loose criteria as to who we'll see. We will pretty much see anybody who's interested in transplant, because we consider our role also in education. We'll take somebody who may not be a good transplant candidate at that moment, tell them what goals they must reach before they can get to the point where they can get a transplant, and then follow up with them until they get to the point where they could be a candidate. This, of course, in addition to indoctrinating quickly people who are immediately good transplant candidates.
Oh, right, okay. When you say getting people to the point where they can be transplanted, usually that's getting their health to a certain level where they can tolerate the procedure? Is that typically the case?
That's exactly right. And
Yeah.
I'll give you the example of someone who smokes.
Mhm.
Someone who smokes usually is not a reasonable transplant candidate because of the harm that smoking can do, not only before, but even more so after the time of transplant.
Oh, I see.
And so we will set some criteria by which they, time frames by which they must stop smoking in order to be a transplant candidate. Sometimes people have significant heart or other vascular disease that needs to be looked into, or in some cases operated on, before they can be a good transplant candidate. We help steer people down that road.
Wow, so yet another reason to quit smoking. There's all kinds of...
Or never start.
Or never start, that there are always great benefits. Okay, well, thank you very much for talking through us for this segment. Let's take a quick break and we'll go into the next segment where we talk about pair donations.